John Weigelt, your coordinating editor for CSAP 17 Audio Companion. I'm sitting here with Dr. Rich Kohler, one of our CSAP 17 authors. Rich, can you share with our audience a little bit about yourself, where you're located, your primary focus of your clinical practice, and maybe a little bit of how you spend your usual day or week, if there is one of those?
Sure, thank you. Thanks for the opportunity to speak today. My name is Rich Kohler. I'm a general surgeon and trauma surgeon down in Mammoth Lakes, California, a small town in the eastern Sierra, about 200 miles south of Reno and 300 miles west of Las Vegas. It's a town of about 7,500 people at an altitude of about 8,000 feet at the base of a ski resort. There are 3 general surgeons here. We break our rotations into a month on the elective service, where we do elective procedures, endoscopy, and don't take any call. And the other 2 weeks, we do a week on, week off, emergency general surgery / trauma call system.
I also know that you've got an interest in thoracic, and so I've sort of set this up with you to try to talk about some things that a general surgeon might encounter related to chest surgery. And I also wanted to pick your brain regarding your transition from an urban to a rural practice. Many of the topics that we're going to talk about can be found in CSAP 17. They're located in the related specialties, and some of the trauma questions come from the trauma category. I also know that you have a passion, a great passion actually, and that is with catastrophic medical assistance. So we're going to talk a little bit about that too. So I'm looking forward to an interesting discussion this morning. Let me start by asking you about this transition from an urban practice, I think that was back in Seattle, to your rural practice now. Can you share that experience with us? Don't sugarcoat it, but just tell it like it was. How about that?
Yeah. After training in general surgery, I did a fellowship in cardiothoracic surgery with an emphasis on thoracic oncology, and I was fortunate enough to get a great job in Seattle, basically right out of the gate, getting to start and develop a minimally invasive pulmonary practice with an obvious emphasis on lung cancer. I did that for a number of years and really enjoyed the kind of multidisciplinary team approach, publishing, teaching residents and fellows, but I guess at some point the balance of work and life was swaying in the work direction, and I ended up finding about this opportunity down here in Mammoth. And a resident and I, who had been in the same training program with me, he and I came down here 7 years ago. Obviously, I am not able to do all the complexity of cases that I did up in Seattle because it's only a 17-bed critical access hospital, and we have a finite number of units of blood here. It's also a 2-hour flight to the nearest tertiary care center that has pulmonology, cardiology, basically any of the specialists. And so it has been kind of a transition from being a master of a few diagnoses and managing surgical conditions to a very broad-based practice with pediatrics, trauma, endoscopy, since there is no GI here. We do all emergent and non-emergent endoscopies. So I feel that I traded complexity for breadth, and I've found it very enjoyable. And despite missing some of the challenges of my former practice life, I do not think at this point that there's much that could take me back to that type of urban practice.
So 2 of you came down there to start the practice, and now there's 3 of you?
Yes. Actually, 2 years ago, we'd gotten busy enough that we hired a 3rd. The real challenge in these rural practices is trying to balance an elective and emergent practice, and we found ourselves being in the middle of an elective day and getting called away for an emergency or having to cancel cases or clinic. So what we really wanted to do was separate the elective from emergent practice, which we accomplished by bringing another resident who had also worked with us in Seattle, and she joined us 2 years ago. We are now able to have one person just doing electives. During that month, there is no call, no jeopardy of being dragged away to do anything else, while the other 2 people still cover trauma and the acute care service. And that really we have found works well, because it's kind of a natural break that every 3 months you can sleep all night, not have to worry about being on call on the weekends or anything like that. You can just have a more traditional Monday through Friday practice. Then you do the 2 months on emergent and acute care practice.
So if I use just your time allocation, it is your practice for all three of you about 1/3 elective and 2/3 emergent?
Correct.
And when you say you sleep all night when you're on that elective practice, I'm sure that doesn't happen because you've got patients you got to worry about, or do you cross cover? Is that how you guys have arranged it?
Fortunately, since we all work together in Seattle and have very similar philosophies and practice patterns, we feel very comfortable taking care of each other's patients and cross-cover completely.
And just out of curiosity, from a medical standpoint, what's your support from internists that can help you with some of the cases, I suspect?
So we have a physician assistant who helps us mostly during our elective practice with clinic and for procedures. And then we do have a hospitalist service here that if we have complex medical and surgical patients, we can share or certainly consult on a number of their patients. The hospital has orthopedists, OBGYN, pediatrics, primary care, hospitalists, and general surgery.
Sounds like you've generated a nice little rural practice that seems to be satisfying everybody. Is that fair?
Yeah, that's fair. The only challenge at this point is that it continues to grow, and you keep getting busier than you want to.
Well, that's a good thing most of the time.
Indeed.
Okay, well, let's talk about a few little things, i.e. that are related to your general surgery and thoracic training. So let's talk about pleural fluid first. There's a question about parapneumonic effusions, and a classification system is offered. Can this classification system help us manage these?
Well, yes. Breaking down pleural fluid and pleural effusions, the first big branch point is exudative and transudative. Transudative, fortunately, does not often require surgical intervention, as the real kind of pathway to success there is identifying the underlying disease and treating it. And if it is heart failure or liver failure or renal failure, one of those, focus on that before you start trying to do anything surgically. I would put a caveat out there that in transudative effusions, as you know, they do talk about sclerodesis, and that can be a mixed bag. I have seen some of the most spectacular failures when people try to sclerose the pleural space with a transudative effusion. And, I remember one from fellowship. I had the guy that they put in a PleurX catheter, which is one of the tunneled catheters, and he ended up getting Pseudomonas in that. And ultimately, when a heart became available for heart transplant, because he was infected, he was not eligible. And because somebody had made that decision to put it in, he ultimately perished. So I always warn people, be very leery of intervening on transudative effusions. Focus more on treating the underlying process.
Are we still making the diagnosis of a transudate versus an exudate with aspiration and then cellular and biochemical analysis of the effusion?
Yes, Light's criteria is still very effective in help differentiating those.
So for a transudate, you basically put a chest tube in and wait?
Well, I would say transudate is probably better off with thoracentesis and then identifying it and not having an indwelling tube. Again, unless you treat that underlying process, you can continue to drain, and then that tube will stay in, and then that is where you risk turning a problem of a transudative effusion into a real problem of an infected pleural space.
And in exudative, that's where a chest tube becomes important or not?
Yeah, I think a lot of times it'll start with thoracentesis as the initial step, just to identify differentiating between transudative and exudative, and then of the types of exudative effusion. There is obviously the different classifications in terms of exudative, fibrilopurulent, organizing, and that also goes with the categories 1, 2, 3, and 4 that is discussed in the critique. Basically, it starts with the simplest, which is just small volume and free-flowing, and most of the time can involve treatment with just antibiotics alone, and sometimes you can get away with simple initial diagnostic aspiration. The lower the volume, the higher chance for success without additional drainage therapies. And as you progress up the scale to larger, still free-flowing, but starting to have pH changes and gram stains that are positive, that starts to obviously bode poorer in terms of prognosis. Again, antibiotic management for the underlying pneumonia, but then if they have a positive culture, then making sure the pleural space is completely drained. You might still get away with small bore catheter, kind of a percutaneously Seldinger type tube or small chest tube. Then as you get more complex, where it has septations or loculations, that is where now you are starting to talk about TPA for drainage or to facilitate drainage. I always talk to patients about the way I think of that kind of stage 3 or starting to organize parapneumonic effusion is the rendered fat in the bottom of the turkey pan the next day after Thanksgiving. And so you can imagine how fluid comes out of a chest tube or pigtail easily, but then when you start to get that gelatinous material, that obviously does not come out well. TPA can turn that gelatinous material back into a liquefied form, which can facilitate draining. Even in ones you are trying to decide whether it is really fully organized or starting to form that pleural peel. And again, I talk to patients about the orange peel on the lung. Sometimes peeling an orange, you get one peel that all comes out, and sometimes you pick at it 100 times and your fingers are all juicy with the orange. And obviously when that's the lung, that's suboptimal. But even in those complex situations that ultimately end up with VATS or open decortication, an attempt at TPA can make the subsequent surgery a little bit easier. And so I tend to, a lot of times it'll be with thoracentesis. Okay, now we have a positive gram stain. Okay, we put in a chest tube. After a day or so of drainage, maybe check another chest x-ray or CT to see if there are loculations that have not drained or if it's incompletely evacuated, or if the patient has not progressed clinically in terms of white count and fevers being gone or totally getting better. In those situations, that's where an attempt at TPA for mobilizing that undrained fluid, and only still if that does not work, or if the patient's showing signs of sepsis or being ill from an infection, or that the pleural space is incompletely drained, that's when VATS is indicated. The surgery, I find that most of the time, even if it involves a lung abscess or something worse, can be done if you plan enough time and are patient. A lot of people kind of put in a scope as a diagnostic maneuver and say, oh, that looks terrible, like a bomb went off. Let's just open them up. Whereas I find if you stay in the right plane, just take your time, and again, your goal is to free up the entirety of the lung so that it can expand and gain pleural apposition of visceral and parietal pleura. Those are the keys to adequate drainage. And if you have to go into the fissure, you have to go to the base, you have to really get everything mobilized. And if you, at the end of the case, when the anesthesiologist blows up the lung, since they've been on single lung isolation, you can have a good sense of the entire space being filled, or that lower lobe still has a peel on it, is not quite so expansive, and you have to keep working until you get good expansion of that lung.
Let me ask you some practical knowledge. I'm sure you're aware that the trauma surgeons are now arguing about what size chest tubes need to be placed for a hemothorax and even sometimes a pneumothorax. And I have not seen anything about the size of the chest tube when we're treating a parapneumonic effusion. Is that something that thoracic surgeons just talk about, or they don't? It's not a big issue. How do you feel about that?
Well, in the earlier phase, it's kind of free-flowing. It doesn't really matter. When it starts to get thicker, and again, we get to that, that the kind of gelatinous material, obviously I think larger bore tube, my default tends to be about a 28 French chest tube, but there is not great science. My rule of thumb has been, if I go for air, I can go for a smaller bore tube, but for blood, I can go bigger. But I rarely find that if you're putting it in for the acute setting, that you have to use the biggest tube available, even if there's blood.
All right, well, let's change the scenario a bit, and let's talk about a malignant effusion. So you've got an elderly patient with a malignant infusion that you drain, and your post-drainage chest X-ray shows that you've got a pneumothorax, the fluid's drained, but you got a non-expanded lung. Is that a common scenario?
Yeah, that unfortunately is a common scenario and a challenge. As I described earlier, getting the lung to fully expand and getting pleural apposition is the goal pretty much of what you want to do in the chest. And if they have a lower lobe that's either not expansile because of an endobronchial obstruction or more commonly pleural implants, then they're not really a candidate for pleurodesis because you're going to put in talc or scuff it up. And again, the upper lobe might stick, but you're still going to have fluid accumulate at the base. And that is where always look at the CT to make sure there's no endobronchial component, or do a bronchoscopy to make sure there's no endobronchial component that you can deal with. But then this is where these tunneled pleural catheters can facilitate drainage at home and minimize dyspnea for the patient. That can be a big help. The good thing with those is that it facilitates days out of the hospitals and can alleviate symptoms. The bad thing is, obviously, the longer it is in, even if it's tunneled, it risks infection. And so in the stage 4 malignancy, unfortunately, the patient's long-term survival is not so great. So these catheters can be good because they're not going to be in that long because the patient is not going to be around that long. That is where, going back to our initial discussion about transidative versus exudative, if it is a transidative effusion and you put in one of those catheters and that can be in there for 6 months or 12 months or even 18 months, that's where you can get into trouble with infection.
And I'm assuming when you talk about placing the tunneled chest tube, this is placed into the pneumothorax for all practical purposes to drain fluid that reaccumulates. Is that what we're talking about?
Correct. Because even a lung that's largely collapsed from tubercle burden, if you add additional pressure of malignant effusion pressing on the mediastinum and or the remaining lung, that can cause dyspnea. And so you can alleviate that with the tube placed, exactly like you said, into the dependent area that you anticipate fluid to reaccumulate. So in the setting where you do not have the airspace, i.e. non-expansile lung, that's where pleurodesis can be remarkably helpful. So if somebody comes in, you drain the malignant effusion, you get the path back, that's where either installation through the chest tube or a VATS mechanical abrasion pleurodesis plus minus talc can be very effective. But that requires good lung apposition of visceral to parietal pleura.
So if the lung re-expands, how do you make the decision between, and you know you've got a malignant effusion, so let's set the stage right here, and how do you make that decision of which people need sclerosing and which people don't need sclerosing, or does everybody get sclerosing?
Well, so again, if you have, you put in a chest tube, you get back the cytology showing malignancy as you described, and their follow-up x-ray shows good lung apposition, that's a great candidate for pleurodesis. However, if they don't, or if there's a question, you can do additional imaging like CT, or at surgery, if you're draining the effusion that you know is malignant, then you can ask your anesthesiologist to stop doing the single lung isolation, blow up the lung, and see if you get good apposition while you're looking through the basilar port to see whether you get good lung expansion. If they get good expansion, that's a great opportunity. Through one additional port, you can do a pretty good mechanical pleurodesis. I tend to do both mechanical pleurodesis with Bovie scratch pad folded on itself with a long curved ring clamp or Landernau lung clamp that has a kind of nice bend on it so that you can get up to the apex and get a good abrasion of the parietal pleura. And then again, if it's malignancy, I don't worry about the long-term question of talc safety, since there is some concern it can cause malignancy. If it's somebody with stage 4 lung cancer that you're doing this, I think the benefits outweigh the risks. In an 18-year-old with a spontaneous pneumo, I do not put in a sclerosing agent like talc.
Do you use a sclerosing agent in that 18-year-old at all, or is it all mechanical?
All mechanical.
All mechanical. If you have to use a sclerosing agent, what's your favorite choice?
In the 18-year-old healthy male?
Oh, and somebody you are willing to use a sclerosing agent, let's put it that way.
Yeah, I use the aerosolized talc. It seems to be pretty simple to apply and seems to get good coverage.
So no tetracycline or any other toxic agents?
I have not used those agents. I tend to use talc.
Well, since you brought it up, it's a nice transition. So let's talk about that young patient who arrives to ski in your community, and he shows up in your emergency department with a pneumothorax, and he says, no, I'm a great skier. I did not fall. And you're asked to evaluate this young, thin, healthy-looking individual. What do you do?
Well, initial evaluation is always for stability. Spontaneous pneumo, even in a healthy patient, can result in tension pneumothorax, so you want to evaluate how they are doing. Checking for underlying causes. There, as you know, are primary spontaneous pneumothoraces, which occur in healthy lung. There are also secondary spontaneous pneumothoraces, which occur in patients with COPD or patients with other underlying lung disease. As part of the current reality, with all this new identification of problems involving vaping, we have seen vape-related. So even if somebody who has what you think would be a primary, you need to do a good history and figure out whether they've been using substances or inhaling anything. And then there is also reasonable data that says, however you reinflate the lung the first time at presentation, you can do about the same whether you aspirate it or put in a small bore tube or even a large bore chest tube. So it really should be based on your comfort level. If it's a second episode, the risk for third and subsequently is markedly higher. So in those patients, if they're hemodynamically normal and doing well, I tend to take them right to surgery and treat them definitively. And in that situation, it would be, the inner tube tire test on single lung isolation and lateral decubitous position. I instill saline and then slowly have the anesthesiologist give that down lung some breaths while holding it under saline, looking for air bubbles, focusing on mostly the apex of the lung or the superior segment of the lower lobe and looking for blisters or bulla or any of the classic findings. And then in the situation where you find an air leak, staple it off. If you are removing a large segment of the upper lobe, sometimes a pleural tent, just releasing the pleura at the apex, can be good to bring that down onto your staple line. And then I do a mechanical pleurodesis at the same time. I tend to use 2 chest tubes because I have 2 or 3 ports, and so I put an angled tube over the diaphragm to drain fluid and a tube up to the apex to drain all the air to, again, obtain good visceral to parietal pleura apposition. In a different scenario, if it's a primary pneumothorax, first-time episode, here earlier in the week, there was a patient who had a collapsed lung for 2 days. They presented to the ER with complete pneumothorax. So in that patient, I put in a 28 French chest tube up to the apex. Follow-up film looked good, no ongoing air leak. 24 hours later, I put him on water seal and then pulled the tube after the chest x-ray showed stability. On their follow-up post-tube film, it also looked good. I just told them, look, if you have this again, don't let somebody shove a chest tube in you. Get seen by somebody who understands that, the second episode and beyond, surgery should be considered to do a more definitive procedure given the high rates of recurrence.
And I'm assuming if that chest tube still had a leak, you would wait to see if it closed before doing anything. How long do you usually wait with the chest tube in a small air leak?
In patients with primary spontaneous pneumothoraces, i.e. good underlying lungs, 24 to 36 hours tends to be enough. but I would wait longer if it shows kind of a small intermittent leak. Sometimes I will try to go to water seal and see what happens. If it's continued to leak while I tried water seal and they failed and the lung dropped again, then I go back to suction. The real caveat is, do you have good pleural apposition? And you always have to be honest and think, if you still have an airspace at the top, but it's 90% up, well, sometimes that's not good enough, because what really heals the lung is good apposition of the two pleural surfaces. So in that situation, sometimes I'll have my IR colleagues put in a small tube at the apex to see if we can get the air leak to go away and the space collapsed. If that's not working, or I have done that and we still have a leak, that's a perfect candidate to go to the operating room. Do a VATS, do the inner tube leak test in the bathtub just to see where the lung is leaking, resect that segment of the lung, and then do either an apical tent, pleurodesis, or both.
Changing the scenario a little bit, what if the patient shows up and says, or you suspect, but it is confirmed that the patient has Marfan syndrome? Is the treatment any different?
Well, again, that's going to be kind of the tall, skinny morphology that we see with this, and somebody who has a higher chance of needing surgical intervention with either blebectomy and pleurodesis.
So you might go earlier on that patient with a first episode?
I think I would still wait and see with a chest tube.
You mentioned the COPD patient as well. So let's say you've got a COPD patient with, on your CT scan, you just got one large bleb. You manage them the same way?
Well, the secondary spontaneous pneumothorax with that underlying emphysema and bullous lung that you are describing is a very challenging cohort of patients. A lot of times I would start with a chest tube, but the failure rate of that was higher. But I did have a number of patients that I would, with terrible underlying lung disease that I just didn't want to operate on. And one single bulla, it sounds like a great operation. You go in and do this bulectomy. That's somebody who I would do an apical tent by releasing the upper pleura and letting it fall down on the staple line, and also consider bovine pericardial reinforced pledgets or something to buttress your staples, because given their underlying lung disease, the parenchyma is very friable. If they have multi-zone bullous disease, you cannot tell that there is one dominant one. Those are patients I would sometimes wait days to weeks with a chest tube, slowly dialing back the suction, hoping that they would heal up on their own. Because, again, operating on them, if you have air leaks after surgery, you're in the same boat you were before surgery, and those are a very challenging cohort.
When you do that pleural tent, do you suture it over the staple line, or you just sort of let the lung come up and press it against the chest wall?
Correct, the latter.
The latter, okay.
Yeah, I did not routinely sew it because, again, especially in that patient population with emphysematous lungs, you don't want to put any additional holes in the lung.
Okay, well, let's talk about another air problem. We've got a CSAP question that talks about a pneumomediastinum after a patient has an asthma attack, while other times we've used blunt chest trauma to get pneumomediastinum. Most of these patients come in, they're found on CT scan. They may complain of a little chest pain, but what do these patients need to evaluate these CT findings, assuming that they're hemodynamically normal and that complaint, and their only complaint, is chest pain?
Well, fortunately, the big problems or big underlying aerodigestive injuries are low, even in the setting of trauma. But especially in the spontaneous situation, in somebody with asthma, that can just often be watched clinically. And as you said, make sure that they remain hemodynamically normal and plus-minus labs. If somebody comes in with benign history, benign exam, normal vitals, a lot of times they don't even warrant admission or hospitalization.
So that trauma patient after blunt chest trauma with minimal complaints, CT findings of pneumomediastinum, you watch them as well?
That person can likely be watched. Yeah, the old pan endoscopy of bronchoscopy and esophagoscopy to rule out large aerodigestive injury. If there's no additional findings on CT and we're talking about a little bit of air, that patient can safely be observed without additional findings. Obviously, if they have an effusion, a thickened esophagus, or a large amount of pneumomediastinum associated with pneumothorax, and you have a chest tube in and a blowing leak, well, that's going to guide you to do more invasive diagnoses.
Well, again, maybe it's an air problem, but let's talk about an emetic injury to the esophagus. Is the typical history that we read about when we're in medical school always present?
Certainly not, but I have had a large number of patients who give me the classic Boerhaave description of violent vomiting and retching and then onset of chest and/or abdominal pain.
And today, with imaging the way it is, I suspect most of these patients start with a chest X-ray, but all of them end up getting a CT scan. Is that fair?
Well, my standard evaluation would be starting with water-soluble contrast. If I have an index of suspicion for esophageal injury due to emesis, I start with water-soluble contrast esophagram. The barium does have some inflammatory reaction within the mediastinum, so if you're worried about leaks, start with water-soluble. If that is negative, then I move to barium. If they are already getting a CT, then I just have them take a couple of big swallows of contrast kind of as they're laying down on the table, so it's kind of a CT esophagram in a sense. But either the water-soluble followed by barium or a CT esophagram, these would be both reasonable ways to initially evaluate the injury.
So let's take one patient who is hemodynamically normal and you make the diagnosis within 4 hours of the event. How do you manage that patient?
Well, the first question based on your diagnosis is it free-flowing perforation, i.e. going into the pleural space, or just widely into the mediastinum? That's the situation where you have to do some sort of drainage and or closure procedure. If they had a small confined, i.e. the teardrop leak, that you can see contrast come out but not collect, that's a different situation. So that is your first big branch point in management once you've made the diagnosis of esophageal leak.
So let's say it's free-flowing into the pleural space.
So early on, the endoscopic management is evolving and certainly becoming more and more useful to help. In this situation, if you are seeing it leaking into the left pleural space and it's a large leak, they are hemodynamically normal and are healthy and don't have any underlying, distal obstruction or concern for malignancy, that is somebody that could be repaired surgically with good results. So you're going to go in, clean out the pleural space, you're going to drain it widely, and you're going to repair the esophagus and buttress it with some sort of tissue. You can use either muscle flap, pleural flap, pericardium, just something to reinforce your repair. In the setting where there's gross contamination and it's been 24 or 48 hours, you worry about the tissues that they're going to be very friable, and any repair is going to start having high rates of subsequent leak. I think those patients combine thoracoscopic debridement, drainage, clean out, and then endoscopic stent management is a good option. And a lot of times our algorithm was the 24-hour line plus clinical criteria in terms of what's their white count, are they septic, how do they look? Okay, they look reasonable, but it's been a long time, but it's a bad leak. That's something that we worry about leaking post-treatment. That's somebody I'm going to think about dual modality therapy with. Endoscopic coverage of the leak and thoracoscopic and or laparoscopic clean out and drainage. There were a couple of situations where we put a double J stent into the leak and then a stent in the esophagus over the leak. So you basically drain the cavity but then exclude the cavity, and then you pull your double J stent once you're comfortable that nothing continues to leak.
When you have an inflammatory condition in the distal esophagus, are they as prone to move as they seem to be when we are putting them in for, let's say, a small rupture during esophageal dilatation?
Yes. That is one of the biggest challenges with covered stents. Since there's no distal obstruction, you don't have any good distal anchoring point, and so esophageal migration continues to be a problem. And so there, typically you place the stent, see where it is on x-ray so you have an idea, and then make sure it doesn't move based on x-rays. You can do a swallow exam, make sure it's completely excluded the leak, and then just be mindful that there's a high risk of that stent moving. And so on daily chest x-ray, just to see if it's changed in location, and then there's also endoscopic repositioning or replacement or even clipping.
In our M&M conferences, we always talk about repositioning them. How easy is that? We don't do it because our GI folks do it. Is it easy to reposition those stents?
A lot of times it is removal and then re-replacement. So it's already kind of flushed into the stomach or heading that way, and then gets into the stomach. Just get rid of that one and put a new one in. We have certainly tried clipping proximally to keep them in place, but nothing has proven perfect.
And for the small rupture, the one usually during a therapeutic intervention, have you had any experience with closing those with clips or not?
Yes, that was back when I was in Seattle. The GI colleagues would clip, then stent to exclude it.
Oh, so clip and stent?
Yep, a lot of times.
And success was pretty good?
Yeah.
Okay. Let's move on to a totally different topic. And we do have a question within CSAP 17 about lung cancer screening, which seems to have come of age. So can I ask you, how do you apply lung cancer screening in a rural population?
Well, here, I guess fortunately, I work with a pretty young, healthy population, and given our altitude of 8,000 feet, there's not a lot of people who have had a long-term smoking history. So we don't do a lot of screening. But certainly the data, as you know, has shown it's a mixed bag. More lesions are identified, but the question has always been, are we removing lesions that would ultimately kill people or not? But certainly if you can remove an earlier stage lung cancer, the better.
So in other words, you're, the first step in any screening program is to identify whether you have got a high-risk population, and in your situation, at least, you do not.
Correct.
Okay, all right. Well, I have one more trauma question before I'm going to ask you about disaster management. And so with your proximity to a ski hill, are helmets being used more and more by the skiers in your area? And have you seen a decrease in head injuries with skiing crashes?
Yes, fortunately in the last number of years since I was a kid, ski helmets were then only on racers and few and far between, but now virtually everybody has them. I see a number of significant ski trauma with pelvic fracture, rib fracture, long bone fractures, and they have a helmet on and have only mild head injury. And then I have certainly seen much less force traumas without helmets, and obviously their head injury can be much more severe. It obviously depends on the mechanism, the fall, and just how you hit your head. But certainly, anecdotally, it seems that there are a lot of people who come in with a broken helmet and a GCS of 15 and no intracranial blood on CT.
So more success getting people to wear helmets while they ski in deference to while they ride their motorcycles.
Well, yeah. Certainly here we have a mountain bike park in the summer, and they actually have a rule that you have to wear a helmet on the mountain bike park, which I think is good. And so a lot of people have full-face helmets if they are doing the downhill stuff. And again, people come in and proudly show me their YouTube video from their chest or helmet cam and show me their completely cracked and shattered helmet. And they're completely intact with a normal scan. So anecdotally, again, these things are really helping.
Well, good. A prevention intervention that works. Good.
Finally.
Let me ask you to give us some insights and practical experience from your ability to work with a local team for disaster management in other areas. Tell us a little bit about that.
Well, initially it started because we realized that our population and proximity of being 300 miles from Los Angeles and our small population makes us a statistical anomaly that if there is a big California earthquake or huge disaster in Southern California, then it's going to take them a while to get to us. And so we felt that we had to be pretty self-sufficient given our resource-limited environment. As I said, the nearest Level 1 facility is 200 miles away and a 2-hour fixed-wing transport in best-case scenario. We began a training program to teach our local medical providers mass casualty response scenarios and teaching them how to perform crikes and chest tubes, hip stabilization with external fixators, just that kind of trying to deal with, the things that you can deal with in a resource-limited environment. That morphed into some international trips responding to medical disasters. On one of those teams, I think 13 of the 15 personnel on this team headed towards a routine medical mission ended up responding to Super Typhoon Haiyan, and that team worked remarkably well as we had all kind of already practiced together. And it just happened that 13 of the 15 of us had been through this kind of mass casualty training program. So we wrote a couple papers about that and felt that it was a good paradigm to have people train up front to go deal with, because normally in our operating rooms we have cautery and suction and light and water. We're kind of used to this very resource-rich environment, and if you put the same team in the dark with headlights, with no electricity, that's a different game. And I think practicing up front helped. The challenges have been that after Haiti and the response that a lot of American residencies and programs went down and put on external fixators trying to help, after the earthquake, there was no follow-up. And so a year later, people are still walking around with their X-fixes on. And so the World Health Organization has really kind of clamped down on their criteria to be able to respond. In our paradigm, since we're a bunch of climbers and backpacks and folks who are used to carrying our pack through rough conditions, has been to kind of be the tip of the spear response, because if you look internationally, it takes about 72 to 100 hours to typically respond to an international disaster. So to get in a team to kind of stabilize those patients until the World Health Organization, MSF, IRC, and the big groups can come in, but we've had a fair bit of resistance from administrative groups saying that, well, you don't have a blood bank, you don't have lab, you don't have x-ray capacity, you don't have ICU capability. But in reality, only a few countries have been able to put together a disaster program that meets all these stringent criteria. And just from my experience, as we were leaving, day 4 or 5 after the disaster, the large groups with their full container ships full of OR equipment, blood banks, x-rays, and ICU capacity, they were still waiting on the tarmac for roads to open while we had gone in and helped patients. I have asked the Pan American Health Organization and the people at the conferences who have had questions after talks I've given, and my question is, well, are you comfortable just saying that the gold standard has to be so rigorous that you don't want a team to get inserted quickly just to bridge that gap? They have yet been unable to answer that question. So as of late, we have not been deploying to international disasters and have been focused more on disaster training for school shooting, Stop the Bleed campaign, etc.
And how often do you practice as a team? Do you have a regular schedule?
No, unfortunately, because of the international pressure to have these more robust groups, we're kind of just in a holding pattern waiting to see what happens. So we've kind of focused more on the community with active shooting training, working with the police department and first responders on Stop the Bleed, at the hospital, middle school, elementary school, things like that.
What about the DMAT teams? Are you an official DMAT team or not?
No.
And why is that? Is that another hoop you got to jump through?
Yes, and I think there are different criteria.
Okay.
My ultimate goal would be to have a similar vein of training to ATLS and ACLS. That is, similar curricula for mass casualty life support, or whatever you want to call it. And that way, every 2 years, people go through a structured program, update their skills, refresh themselves, and work together in a multidisciplinary approach. I think in the future, making it this similar format to what has already proved successful and just have it for mass casualty, that way, with the increased number of school shootings and the like, there's going to be a need for that.
Let me ask you, with your practice and your emphasis on the community, is that something that you have buy-in from most of the medical community so that when you practice or put on an event, whether it be a live event or whether it be just a practice scenario, do you get pretty good response from everybody?
Yeah, the usual players who tend to be most interested are ER docs and surgeons and orthopedics. But we started doing this. You realize that the sheriff's department isn't communicating with the police department, who's not always communicating with the hospital. So by bringing these exercises together, you realize that you get to know the players. So God forbid, if there is an event like this, you kind of already know, oh, police is going to do this, fire is going to do that. First responders will be doing this. The hospital is going to react this way. And so you start to coordinate these independent silos so that they are talking together and used to working together. And, here again, the search and rescue is an integral part to a lot of the mountain rescues. And how do they tie in with the paramedics? And how do they tie in with the hospital? So I think the more you can get these independent organizations to train and practice together, obviously come crunch time, the better they are to work together.
That is such a great comment, but I also want to tell you that it happens in the urban environment too. The communication between the people who are responding and everybody thinks they're doing their job correctly, and then when you debrief on those practice sessions, you find the communication in between, which is so essential to proper use of resources, proper treatment of the injuries, is just not happening. So I would not bemoan the idea that this is your small community. It happens in the big communities too. Well, I see our time is up this morning, Rich. I really enjoyed talking to you. I think you've brought us some unique ideas about treating some problems in the chest cavity, as well as listening to your travels from an urban environment to a rural environment, as well as this last discussion about disaster management. I wish you well. I thank you for your contribution to CSAP, and I guess from the perspective of your practice, do you have any comments about CSAP or CSAP Audio Companion you'd like to share with the audience this morning?
Well, I have certainly appreciated the opportunity to not only speak today, but to participate in CSAP for the last number of years, and really appreciate the discussions we've had and the learning through this process. I think it's not only been fun, but very educational for me. So I appreciate it.
Okay. Well, we appreciate your efforts and your contributions.
All right. Thanks, John.
That's it for this category of the CSAP 17 Audio Companion.